So in this PowerPoint, we are going to focus on hemodialysis, peritoneal dialysis, and kidney transplant. If you ask me, when patient need dialysis or transplant, answer is when the kidney does not work or when kidney are not working properly, patient may require dialysis or kidney transplant. So it is the replacement therapy. By this replacement therapy, we can eliminate the waste product from the body. So the replacement therapy are dialysis or transplant. The two type of dialysis. One is hemodialysis and another is the peritoneal dialysis, right? Here we going to talk about the hemodialysis first. But hemodialysis or peritoneal dialysis, both are dialysis of the kidney. So dialysis is a treatment that filter and purify the blood using a machine. You can say this machine is called dialysis machine. And this helps to keep your fluid and electrolyte in balance when the kidney cannot do their job. So first of all are hemodialysis, right? So in this PowerPoint, we are going to focus about the hemodialysis. On the same time, I will explain what are the common question NCLEX board asks. So hemodialysis is an intermittent renal replacement therapy involving the process of cleaning the client blood. So it involves the diffusion of the dissolved particles from one fluid compartment into the another across the semi-permeable membrane. The client blood flow through one fluid compartment of a dialyzer filter, and the dialyzer is in another fluid compartment. So this is the mechanism of dialysis machine or osmosis we are going to focus, right? So the basic principle of hemodialysis, they eliminate the excess fluid or electrolyte, make a balance of electrolyte and waste product from the body, and used in the patient with acute or chronic kidney problem. So hemodialysis mostly we use for chronic kidney problem, but in some clinical scenario like acute kidney failure, we use hemodialysis as well. Usually hemodialysis done 3 times a week, right? Now, what are the function of hemodialysis? Easy way to explain what are the function of the kidney. It is same the function of hemodialysis or the function of any dialysis. If I easily explain, hemodialysis or dialysis is the treatment that filter and purify the blood, but using a machine. And this helps keep our fluid and electrolyte imbalance if the kidney does not work well, right? So let me read it. Cleaning the blood for accumulate the waste product. So during the metabolism process, the nitrogenous substance or protein break down and produce the waste product. And this waste product, like ammonia, you need to expel out from your body. If you do not, the problem start. Nobody want to face the problem. So remove byproduct of protein metabolism, such as urea, creatinine, and blood urea nitrogen. They are waste product. Body do not tolerate them. And so remove the excess body fluid and maintain the buffer system. And buffer system is important to make the balance acid and base, and also maintain proper adequate electrolyte balance in your body. If electrolyte imbalance, buffer system will be imbalanced. So no chemical reaction occur. Acid base balance will be imbalanced, right? So next here, this is the hemodialysis. We can see the picture. This is the hemodialysis machine, and fistula. In this portion we make fistula, and this one is called filter. The kidney, you see the nephron, it is worked like a nephron, and this is the dialysis machine. So when your patient need dialysis as a RN or LPN, we have to know what are the pre-procedure, right? And it is very important to patient teaching or how to take care of intra-procedure or post-procedure. So before start this hemodialysis, what you could do during the process, what you should do, and after the process, what you should do, and also what you educate your patient. This is the area we are going to focus right now. And hemodialysis, a common question sometimes NCLEX board asks. Before start, we hold some medication. What does it mean? What medication? Like antihypertensive medication, or also give them anticoagulant during the process. But I said hold the antihypertensive and anticoagulant before start dialysis, right? And 3 to 4 times per week we could do hemodialysis, and every setting it is 4 hours each session. So next here, the principle of hemodialysis, the principle. Let me read it. A semi-permeable membrane is made a thin porous cellophane. So means, let me show you the picture. So like this is the two solution separated by semi-permeable membrane. And this membrane has a lot of small pore. And this fluid number 1 or outside the cell, there are so many cells, means concentration is more. And the outside the cell concentration is less. Because of the difference between the concentration and fluid supposed to move one side to the other side, it depends upon the concentration gradient, it depends upon the pore size of the membrane, Also, it depends on the size of the molecules and electricity of the molecules, positive or negative. This is the basic principle of osmosis, and kidney or hemodialysis work on the basis of osmosis. So here we go next. So the pore size of the membrane allow the small particles to pass through, such as urea, creatinine, uric acid, and waste molecules. So this is the waste product. We do not need them. During the dialysis, or kidney eliminate them from your body. The protein, bacteria, and some blood cell are too large to pass through, right? So the size of the molecule, the size of the pore in the membrane is important. The client blood flows into the dialyzer. The movement of substance occur from the blood to dialysate by the principle of osmosis, or diffusion, or ultrafiltration. This is the mechanism of crossing the materials. Diffusion of the movement of the particles from one area to the other, concentration to one or low concentration, right? So here in this picture, we can see the supply are needed for dialysis, or what are the equipment is used in hemodialysis. The basic of hemodialysis equipment, like here, we need, first of all, hemodialysis machine, right? Also, we need the fluid, water, distilled water, some tubing, antiseptic solution, and also dialyzer. This is the dialyzer, you can see. Okay. So next here, the basic principle of hemodialysis, we are going to little bit discuss from a picture, through a picture. Right. So you can see this is the human hand, the artery and vein. So it's artery and vein. Usually, normal healthy individual, it is not like this. You can see artery and vein is connected each other, but in our body, only heart, lungs, or tissue level, where the artery and vein communicate through the arterioles, venules, and then capillary, not directly, right? So we make a shunt or grafting, and they make it, and it's called fistula. The fistula, when we make and then attached with the dialyzing machine, right? So in the dialyzing machine, there are one of the small unit is called dialyzer, right? So here you can see the line from artery to apparatus. So dialyzer is connected to the body through the fistula or artery. And this is the pumping machine as well. And this one is called tubing or selectively permeable membrane, which is called dialyzer, right? And also they are communicate with the fluid in the outside. during this process, we can add some medication like anticoagulant, what is prevent any unaccepted clotting. In this pages, we are going to the principle of hemodialysis. Let me read it. Osmosis is the movement of the fluid across the semi-permeable membrane from one area of low concentration of particles to the area of the higher concentration of particles. So this is the two areas, right? So the concentration where is less, fluid is go through that area. So movement of fluid across the semi-permeable, this is the semi-permeable membrane, right? From one area of low concentration to the particles of the area of higher concentration, right? So this is a movement. So ultrafiltration is occurred here. Ultrafiltration is the movement of fluid across the semi-permeable membrane, what kidney basically do. Dialysate bath means a dialysate bath is a composed of water and major electrolyte, right? Next here, the intervention as a RN or LPN, we need it very badly, right? So what are the intervention? As I told at the beginning, before start the procedure, we ensure the patient vascular access is working well, or check for, like, let me show you the picture. So before start this process, we could check this artery, it is working well or not. More accurately, medical terminology, I want to tell you, we check the vascular access or check for bruit, thrill, or maturity of the fistula. So when we make the channel here, grafting or fistula, they will mature or not. What does it mean? Mature means they are ready to work or not, maturity. But when you put the stethoscope over here, or if you feel by your hand, you can find the bruit or thrill in distal pulses. Access the vital sign. We check the vital sign before start the procedure, and also we'll check the laboratory bellows. And every day by using same machine, we can check the patient body weight, right? And during the procedure, we could monitoring the vital sign, especially blood pressure, because patient chance to develop hypotension or cramping, patient complain nausea, vomiting, bleeding, chance of bleeding. Also, we admin anticoagulant to prevent clot as prescribed. Administer potassium sulfate to reverse the heparin if needed. And after procedure, decrease the blood pressure and lab value expected, and compare the weight to before procedure to estimate the fluid removed from the body, right? So let me read it with you. Monitor the vital sign before, during, and after the procedure or dialysis. The client temperature may elevate because of slight warming of the blood from dialysis machine. So, my friend, this is the dialysis machine. I can show you a picture like this. Here. So when blood go through this machine or fluid go through this machine, and machine will run 4 hours, because in every setting patient have to continue 4 hours each session. Definitely blood or fluid will be get heated or increase the temperature, and your body have to adjust with it. It is very important. So notify the RN, who will notify healthcare provider about excessive temperature elevation, because this could indicate the sepsis. First of all, adjustment of the fluid temperature. Secondly, if any kind of infection occur, that times can cause to develop sepsis, we could notify healthcare provider. If sepsis are not controlled, patient chance to develop septicemia, and septicemia lead to shock, and shock lead to death. So also we could monitor laboratory values, particularly creatinine and blood urea nitrogen, complete blood cell count, WBC, red blood cell, and platelet, right? Monitor the client for fluid overload. As an RN, every day we check the patient body weight, right? And especially dialysis before and after. So before and after indicate how much fluid loss or removed from the body. Basically, 1 liter fluid equal to 1 kg. So weight of the client before and after dialysis to determine the fluid loss. Note that the client will not urinate or will urinate same amount. Continue. Monitor the patency of blood across the device. Monitor the bleeding, and heparin is added to the dialysis bath to prevent the clot from forming within the dialyzer or blood tubing. And also monitor for hypovolemia or shock during dialysis. Provide adequate nutrition, because during the dialysis, a lot of micronutrient loss, you have to refill it. Provide adequate nutrition. Identify the client reaction to the treatment and support the coping mechanism. Encouraging them, right? So it is very important to give them a good counseling. Next, withhold antihypertensive. As I told you before, a common question usually NCLEX board asks, before start hemodialysis, we hold antihypertensive and anticoagulant before start dialysis. So here the other medication that can affect the blood pressure or result in hypotension until after the hemodialysis treatment. Also withdraw the medication that could be removed via dialysis, such as water-soluble vitamin, certain antibiotic, and digoxin. Keep it in mind, during the dialysis, patient tends to develop hypotension. So if the patient has to take regular dose of antihypertensive because of their blood pressure, we could hold it. Why? Because antihypertension medication reduce the blood pressure. During dialysis, chance to reduce blood pressure. Both can chance to develop hypotension, lead to hypovolemia, and lead to the shock, right? The other medication that chance to eliminate during the dialysis, like water-soluble vitamin, certain antibiotics, or cardiac medication like digoxin or digoxin. In this picture, you can see the access for hemodialysis. So we can do the hemodialysis in subclavian artery or femoral arteries, or we can do it in radial arteries, right? So here we are going to talk about the subclavian and femoral catheter. But before to go subclavian and femoral catheter, I could tell you something. So this is the picture. You can see the radial cephalic AB fistula. So this fistula usually we make in wrist joint, over the wrist joint, in between radial artery or cephalic and or between cephalic vein. This is called fistula or shunt. This one we make for continue the dialysis process. But to get maturity or to be functioning, this fistula take time, usually 6 weeks. But your patient need the dialysis now, then what you will do? In that cases, we go for temporary pathway to make, and this is for like catheter make, catheter in subclavian artery or catheter in femoral artery. So subclavian or femoral catheter is a temporary process. Like the 6 weeks patient have to wait to get maturity, the fistula. In this picture, you can see the shunt make, artery and vein, and it look like this. If you feel it, you can get the thrill. If you put the stethoscope, you can get the bruit, and it indicate the fistula is mature to start the work. In this picture, showing step-by-step placement of subclavian catheter. So the danger side of this subclavian, the chance of infection, and infection easily spread out to the lungs, heart. And this area is the femoral catheter. We can do it like here, the femoral artery and vein. So this one, my friend, it is important to let you know that the femoral area more chance to get infection. So you have to educate your patient, or we can clean the perineum because more chance to spread infection. In relation to the subclavian, they have a less chance than femoral to spread the infection. But if infection spread once, that will be more dangerous than femoral. Let me recap it. Out of these two, femoral or subclavian, both are temporary catheter for AKI or dialysis before to start fistula. Out of these two, compare contrast, the chance of infection rate is high in femoral, but is safer than the subclavian. If one subclavian is spread infection, it is easily spread to the lungs. In case of femoral, as a patient will get time to be cured, right? To get in heart or system. So let me read it, the access. So subclavian, femoral, or fistula, all is connectively called access for hemodialysis, right? So subclavian vein or femoral vein catheter may be inserted for short-term or temporary use, like acute kidney shutdown, acute kidney infection. The catheter is used until a fistula or graft mature or develop, which is typically takes 6 weeks. So if you ask me what are the maturity means, it does mean the fistula ready to work, right? So usually take 6 weeks. What are the intervention? If patient needs subclavian or femoral catheter, monitor the insertion site for inflammation like redness, bleeding, temperature, swelling, or any other sign of infection or catheter dislodgement. This catheter should only be used for dialysis treatment and accessed by the dialysis personnel. So maintain an occlusive dressing every time and prevent to get wet. What else? Subclavian, the catheter is usually filled with a heparin and also try to maintain the patency between dialysis treatments. Heparin is aspirated from the line before dialysis. So heparin is an anticoagulant. They can prevent the clot formation. The catheter should not be uncapped except for dialysis treatment, right? Very important. So it can prevent the infection. Catheter may be left in place for up to 6 weeks if no sign and symptom of infection or inflammation. In this picture, I already explained, but I'm just going to recap a little bit. Like this is the subclavian catheter, this is femoral catheter, and this is fistula. Fistula in between radial artery and cephalic vein. Right. In this picture, you can see the incision is done and joined to artery and vein together is called radiocephalic fistula, like this picture. Next, femoral vein catheter. We're just going to focus the here femoral vein. So once patient done the femoral catheter, then what you educate your patient. Monitor the extremity for circulation, temperature and pulses. Vital sign monitoring prevent the disconnection of the catheter, because the groin is not also it is very important, because the groin is not a clean site, so meticulous perineal care is so important. Also use an IV infusion pump or controller with micro drip tubing if heparin infusion through the catheter. It is very important for anaphylaxis board. The client with a femoral vein catheter should not sit up more than 45 degrees of, right? And also forward, because lean forward, the catheter may chance of bending or kink, or they can cause the occlusion. So in this phase, we're going to focus on excess of hemodialysis, especially on fistula. There are three types of fistula. One is called external arteriovenous fistula, right? Another is called the internal arteriovenous fistula, right? In this picture, you can see picture 1, 2, 3. So all of them basically vascular access for hemodialysis. Picture number 1 or A, that is the external shunt. See, the blue one is a vein and the artery is there. So the shunt is made in between artery and vein. Usually that one is used like the carotid artery of cow, bovine, and they use it and continue this one. This is called external shunt. Picture number 2, there are no external synthetic or cow carotid artery are used, just artery and vein joined together, and this is called internal fistula or internal arteriovenous fistula. Arteriovenous means artery joined with vein together and make a fistula. And number 3, it is internal arteriovenous grafting. This two is fistula and this is the grafting. So this is the graft and join artery and vein together. Grafting, right? And number 4, it is picture of graft while connect with hemodialysis machine. So in that case, it is very important to discuss about the patient education. Very important, my friend. So during this process or hemodialysis, the increase the protein intake after dialysis, we can tell our patient because protein loss occur. So let me read it, my friend. External arteriovenous shunt. 2 cannulas are surgically inserted into a artery and vein in the forearms like this. 2 artery and veins are connected, right, in the wrist. The cannulas are connected to form a U shape. This is the U shape. And here, blood flow connect artery and shunt. The tube leading to the member of compartment of the dialyzer is connected to arterial cannula. The blood fill the membrane compartment and passing through the dialyzer and return back to the client through the tube. When dialysis is complete, the cannula are clamped and reattached, right? And next here, what are the advantages of external shunt? The external arteriovenous shunt can be used immediately and no venipuncture is done. Disadvantage: disconnect or dislodged easily. Also risks of hemorrhage, risks of infection or risks of clotting. Potential for the skin erosion. What are the intervention? So during take care of the patient who undergo the hemodialysis, so always try to avoid getting the shunt wet or a dressing always wrapped completely around the shunt to keep it dry. What else? What are the other intervention? So reinforce the teaching the client that the shunt extremity should not be used for measuring blood pressure, collecting blood, or draw the blood, or IV channel, or any administration of injection. Fold the back, the dressing to expose the shunt tubing. Monitor the skin integrity around the insertion site. Also auscultate for bruit and palpate for thrill. So when you put the stethoscope over the fistula, you can sound the bruit. When you feel the by your hand, you can feel the thrill, right? It indicates fistula is healthy, ready to work. Notify the RN immediately, who will notify the healthcare provider if any sign of clot, sign of infection, sign of hemorrhage or inflammation. Here the showing some note about the sign of clotting, like fibrin. If formation excess clot, fibrin clot is a sign of clotting, or absence of bruit, or absence of thrill during the palpation, absence of bruit during auscultation, coolness, tingling sensation. So they are the sign of clotting. Next here, internal arteriovenous fistula. Internal. So this is the four picture again. Picture number 1 is the external shunt. Picture 2, it is the internal, right? There are some advantages of internal shunt rather than the external. So what is it is? A permanent access of choice. So internal shunt is the permanent access of choice in case of irreversible kidney failure or CKD. The fistula is created surgically by anastomosis a large artery and vein. And as I told you, usually we use the cephalic vein. The flow of the arterial blood into the venous system because the vein to become engorged or become mature or developed to work. So usually it takes 4 to 6 weeks, right? In this time, you can tell your patient squeezing the ball. So when the squeezing the ball, it helps to fistula get mature. It is the exercise basically. The fistula is required to mature before it can be used. Subclavian or femoral catheter, peritoneal dialysis, or any external arteriovenous shunt can be used for dialysis while fistula is going to get mature. So usually fistula get maturity take 4 to 6 weeks. In this 4 to 6 weeks, we go for peritoneal dialysis or subclavian or femoral catheter for dialysis. What are the advantages of internal arteriovenous fistula? Like, because of fistula is internal, the risks of clot or bleeding are low. And fistula can easily identify. And also the incidence of infection is low because it is internal and direct communication artery vein. Once the healing has occurred, no external dressing is required because it is internal. So internal arteriovenous fistula here also showing a picture. Brachial artery and cephalic artery in elbow joint. Disadvantage. The major problem of this is called arterial still syndrome develop. So what is arterial still syndrome? So this can develop in a client with an internal arteriovenous fistula, and in this complication too much blood is diverted to the vein and artery perfusion to the hand is compromised. So I said the other sign and symptom or disadvantages are patient chance to develop aneurysm. Why aneurysm? Because of weakness of the wall and artery or vein easily dilated or dysfunction of the wall. Infiltrate the needle during the dialysis, and that can occur hematoma. All of these are the disadvantages. There's some more information. Let me read it about the internal arteriovenous fistula or grafting. This picture number C is a grafting. So internal graft may be used for chronic dialysis who do not have adequate blood vessel for create a fistula, or artificial graft made to collect the artery from cow is called bovine cow carotid artery. The procedure involves the anastomosis of an artery and vein. Anastomosis means direct communication in between artery and vein. This graft can be used 2 weeks after insertion, and complications of the graft include clot or aneurysm and infection. So now go here, intervention for arteriovenous fistula and graft. What are the intervention? Reinforce the teaching the client that the extremity should not be used for monitoring the blood pressure, drawing the blood, placing IV line, or administering injection, and that the client should inform all healthcare provider. Also reinforce the teaching the client with arteriovenous fistula to perform hand flexion exercise like ball quizzing. Note the temperature or capillary refill of the extremities. So you could check the temperature for infection or capillary refill for circulation is good or not. If any abnormalities, we could notify the patient, healthcare provider. What are the others intervention or patient care or patient teaching? We could monitor for the clot like tingling sensation, discomfort, or inability to palpate the thrill or bruit. Also monitor for arterial still syndrome, monitor for infection, or monitor the lungs and heart sound. How we have to see the infection? See for temperature increase, any other sign of the inflammation, swelling, redness, dislodgement. If anything is happened, always notify RN, and RN immediately notify to the healthcare provider to ensure the patency, palpate for the thrill, and auscultate for the bruit. If absence them, something wrong, right? So before go to the complication of hemodialysis, it is very important to tell something more. So I said during hemodialysis, a good number of the protein loss. So we make sure increase the protein intake after dialysis, as a protein is lost with each exchange. Avoid the carrying item with the arm with excess site. So the hand, we make the fistula or graft, always educate your patient to avoid this hand to carry out any materials, carrying the items. And do not sleep on the arm with excess line or excess site. Perform hand exercise to mature fistula. And what are the complication of hemodialysis? So let me read it first. You see, this is a so many wire, and this is the cannula and dialysis machine, same two picture. So because of this access, the chance of hemorrhage, infection, and infection lead to the septicemia or sepsis, which lead to the shock. Because of opening or handling or make the fistula, the chance of spread the infectious disease like hepatitis. What else? Also can cause air embolism or disequilibrium syndrome, electrolyte alteration, and encephalopathy. So disequilibrium syndrome, this is the symptoms. Actually disequilibrium are patient feel nausea, vomiting, decrease the level of consciousness, or seizure. So because disequilibrium syndrome develop due to increase the intracranial pressure. Okay. So disequilibrium syndrome occur shortly after beginning the hemodialysis or peritoneal dialysis and causes by rapid correction of metabolic abnormalities. Let me recap it. The complication disequilibrium syndrome is occur shortly after beginning the hemodialysis or peritoneal dialysis. caused by rapid correction of metabolic abnormalities. The basic and most common sign and symptom of disequilibrium syndrome are nausea and vomiting, patient feel drowsiness, headache, disorientation, and can progress to the seizure and coma and death. So, during the dialysis, to prevent the disequilibrium syndrome, it is good to treatment is prevention with a slow reduction of BUN or creatinine. And also patient develop hypotension during the hemodialysis. It is challenging to face. Hypotension, in case of hypotension, administer IV fluid or colloid or water or as prescribed we use it. And also slow exchange rate, right? So here, let me, and definitely if any sign and symptom of the complication develop because of hemodialysis, we always notify healthcare provider. Here showing another complication is called ear embolism. If your patient develop the ear embolism, how we could prevent it? So ear embolism is occur when the ear enter the catheter system and is complicated of hemodialysis, either because of catheter or during the hemodialysis air bubble can enter in the circulation. The sign of ear embolism include shortness of breath, tachycardia, chest pain, hypotension, reduced oxygen saturation, cyanosis, anxiety, or change the sensorium. Once your patient develop ear embolism, what we could do? Ear embolism is a client receiving hemodialysis, and what should do? We could stop the hemodialysis, turn the patient on left side with a head down, so low the head of the bed. Notify healthcare provider and rapid response team for hospitalize the client. Admit oxygen, assess the vital sign and pulse oximetry, and document the events, action taken, and client response. So this is the step-by-step process if your patient develop ear embolism. As a RN or LPN or healthcare provider, we have to follow this. So here we go to talk about the peritoneal dialysis. So you see, peritoneal dialysis, I said, as like a hemodialysis, peritoneal dialysis also work through the principle of osmosis, right? So peritoneal dialysis, it is the instillation and dwelling of hypertonic dialysate solution in peritoneal cavity to remove the waste product, and it is the alternative to hemodialysis for old adult or intolerance of anticoagulant or vascular access facilities. So peritoneal dialysis, I can show you a picture like this one. This is the peritoneum layer, right? So we can put the catheter, and this is the good water go inside the peritoneum, and waste product come, and then waste product is go down to the outside in the bag. So peritoneal dialysis, we make it in the peritoneum, right? This is an alternative of hemodialysis. Why we go for peritoneal dialysis? Like you make a fistula, and fistula take time to be mature. This time we can go peritoneal dialysis. Like your patient do not like the kidney transplant or hemodialysis, we can choose the peritoneal dialysis. Or if the patient is older, or intolerance to the anticoagulant during hemodialysis, then we go peritoneal dialysis. Or vascular access difficulties to make, we choose the peritoneal dialysis. So difference between hemodialysis and peritoneal dialysis. Already you know, peritoneal dialysis is a temporary process, and we use the hypertonic dialysate solution. You see the solution, dialysate solution. This solution passing through in the peritoneum. So, and to remove the waste product, so you can see another channel here. It is passing the waste product. But here the hemodialysis, we use the dialysis machine. We make fistula, and basically it is done 4 hours in every session, 3 times per week, right? So like, let me go back in the PowerPoint here. The peritoneum act as a dialyzing membrane to attaching dialysis, and membrane is accessed by insertion of peritoneal dialysis catheter through the abdomen. The peritoneal dialysis works on the principle of osmosis. The peritoneal membrane is a large porous and allowing the solute and dilute to move via osmosis. So peritoneal cavity, basically the reach of capillaries. Therefore, it provides and ready access to the blood supply. So the picture you can see, this is the peritoneal cavity. Peritoneal cavity covered by the peritoneal membrane. The peritoneal membrane is full of capillaries where the arterial and venous blood is exchanging. So these facilities we use for peritoneal dialysis. So this is the channel we put dialysis fluid passing inside, exchange with waste product, and waste product came out. The fluid plus waste come out. In second picture showing the dialysate, and this one is empty bag, which is the collected the waste product. Exchanging occur in peritoneal cavity. In this picture showing the waste fluid or chemicals and dialysate fluid, it is the membrane, peritoneal membrane, and then because of osmosis process, the waste product came out, right, or drain out. And next here, what are the contraindication to the peritoneal dialysis? So in what medical condition we are not allowing to continue peritoneal dialysis? If patient have peritonitis. Peritonitis means this is the peritoneal cavity covered by the peritoneal membrane. If the inflammation of the peritoneal membrane, patient develop peritonitis. So if your patient have a peritonitis, we are not allowing them for peritoneal dialysis. If patient has recent abdominal surgery or abdominal adhesion or other gastrointestinal problems such as diverticulosis. And what are the access for peritoneal dialysis? Okay, a siliconized rubber catheter basically we use and surgically inserted into the peritoneal cavity to allow infusion of fluid is called dialysis fluid. Catheter side is covered by sterile dressing gauze that is changed daily or changed if it get wet. Usually we prefer to insert the side 3 to 5 centimeter below umbilicus. And this area is relatively avascular. Which area? The area we choose to insert the catheter. It is below 3 to 5 centimeter of umbilicus. So you see, it is below the umbilicus, 3 to 5 centimeter, where the catheter insert. But keep in mind, during the insertion, if the perforation of the organ, it will make a problem. So in this picture, showing the different layer of the abdomen, outer layer the skin, then subcutaneous layer, muscle layer, and then peritoneal membrane. So this it is called peritoneal cavity. So you should insert the catheter and keep in mind there are some structure behind this membrane like bowel, urinary bladder, rectum. Better to do not too much forcefully do it, right? To prevent the perforation. So the catheter is tunneled under the skin through the fat and muscle tissue and to get inside the peritoneum. And over a period of 1 to 2 weeks after insertion, the fibroblast and blood vessel grow around the cuff. If the client is scheduled for transplant surgery, the peritoneal dialysis catheter may either be removed or left in place if the need for dialysis is suspected post-transplant. So what are the dialysis solution we use? And dialysis solution should be sterile, and all dialysis solutions are prescribed by healthcare provider. The higher the glucose concentration, the greater the hypertonicity and the amount of the fluid removed during a peritoneal dialysis. Inserting the glucose concentration increase the concentration of the active particles that cause the osmosis. So what we could keep in mind, during the dilute solution choice. Okay, so if the hyperkalemia is not a problem, hyperkalemia means when the potassium level go up. So if not a problem, potassium may be added with each bag. Heparin is added to prevent the clot. Some antibiotics should be added, may be added to prevent the peritonitis, because during the peritoneal dialysis, the major and dangerous signs complication to develop peritonitis. Okay, peritonitis. So because during the peritoneal dialysis, the chance of the or risks to develop peritonitis or perforation or insulin may be added if your patient have a diabetic. So peritoneal dialysis infusion, usually one infusion dwelling and drain is considered one exchange. 1 to 2 liter dialysis as prescribed. Dwell time, the amount of time that is dialysis solution remain in the peritoneal cavity, and drainage, the fluid drain out of body by gravities. So in this picture, we see dialysis solution we put here, that is sterile, then it should be kept inside the peritoneal cavity, and because of the process, the waste product go down because of gravity and drain out inside the bag. It's called waste product. And during the peritoneal dialysis, what are the intervention we have to educate our patient? First of all, before treatment or before start to the dialysis. So always we could access the body weight and also warm the dialysis solution and use the sterile technique when accessing the catheter insert in the abdominal wall. And now go for during the treatment. Let me recap a little bit about the before treatment. Monitor the vital sign, everyday measurement body weight, and use same scale, and tell your patient to void the blood urine and monitor the electrolyte and glucose level, and also monitor the peritoneal catheter dressing and site. And during the intervention or during the peritoneal dialysis, what we could do, intra procedure, monitor vital sign, monitor for respiratory distress, pain, or discomfort, monitor the sign of pulmonary edema, monitor for hypotension or hypertension, monitor for malaise, nausea, and vomiting. What else? So monitor for the catheter site for dressing, is it bleeding or get wet? Monitor dwell time and as prescribed, and do not allow the dwell time to extend beyond what mentioned in prescription. And also initiate the outflow and turn the catheter from side to side if outflow is slow to start. Monitor the outflow, which should be continuous stream after cramp is open, and monitor the outflow for color and clarities. Color is important. So if the color is cloudy, indicate the infection. If color is bloody red, it indicate the blood is coming. So during the process, we have to keep it eye open to see any kind of complication or risks like peritonitis or leakage, bloody output, right? Also monitor intake and output accurately. So always input should be equal to the output. If we say output is more than input, there's something wrong. We could notify to the healthcare provider. What else? So during the treatment, outflow greater than the inflow should be reported healthcare provider. Also, we have to notify to the RN if we see any kind of complication. What are the complications? As I mentioned, peritonitis, right? If the peritonitis, the outflow should be cloudy, okay? Or we can check for any leakage, or we can check the output of peritoneal dialysis. If it is bloody or cloudy, indicate the infection or protein may be lost in dialysate. So complication find out and prevention is very important during the peritoneal dialysis. So it is also important tell your patient to compare inflow and outflow of dialysate and keep the outflow lower than the patient abdomen and monitor the color of outflow, and it should be clear and light yellow because this is the urine. So sometimes blood come out, sometimes it is cloudy outflow, indicate the infection, right? So the type of peritoneal dialysis, one type of peritoneal dialysis called continuous ambulatory peritoneal dialysis. So peritoneal dialysis, we use a portable machine and you can carry it with you even you go outside, like you go in your job, you can keep it up with you. Continuous ambulatory. Ambulatory means movement. So closely resemble the renal function because it is a continuous process. Does not require a machine for procedure, promote the client independence, and the client perform the self-dialysis 24 hours a day or 7 days a week. So the 4 dialysis cycle are usually administered in 24 hours, and dialysate usually 1.5 to 2 liters. After dwelling, the bag is placed lower than insertion site so that fluid drain easily because of gravity, right? So in this picture, I already explained, and here showing a portable peritoneal dialysis. Portable it is. And sometimes patient use during the sleeping time. Okay. The name of this is called automated dialysis and require a peritoneal cycling machine. Automated dialysis can be done as intermittent peritoneal dialysis and continuous cycling peritoneal dialysis, and also nightly peritoneal dialysis. So patient can continue it and they go for the sleep. In this picture showing peritoneal dialysis machine and insert by patient themselves. And here we are going to show some complication of peritoneal dialysis. The major and dangerous important complication of peritonitis. So if patient develop the peritonitis, patient usually complain the fever, purulent drainage, or erythema, swelling, or discolor dialysis, and sometimes protein loss and increase the protein in the diet. If protein loss, increase the protein in the diet. So I'm saying infection is a concern with peritoneal dialysis. Site of infection are either at the catheter insertion site or peritoneum, which can cause peritonitis. So this is the outer layer of peritoneal cavity lining by peritoneal membrane, and this is the insertion. If this membrane is infected, inflammation occurrence called peritonitis. Monitor for the sign and symptom of peritonitis. It is the infection, so we will get the sign of infection like fever, increase the body temperature, or outflow should be cloudy, rebound abdominal tenderness, abdominal pain, general malaise, nausea, and vomiting. And I said the output should be cloudy, and definitely we give them antibiotic to prevent the infection. So how we will avoid the infection? Avoid the infection by maintaining meticulous sterile procedure, maintaining the precursor, prevent the catheter insertion site dressing from becoming get wet, or changing the dressing if get wet, right? And always following institutional procedure and protocol. What are the other complications? Other complication, abdominal pain. In this picture, showing the peritoneal dialysis. This is the catheter. Peritoneal irritation during the inflow commonly causes pain during the first few exchange, and the pain usually disappear after 1 or 2 weeks of dialysate treatment. Other complication, abdominal outflow characteristics are indicate of complication. So this is the fluid we passing. If the fluid come outside, if it look like this, it indicate problem. What it indicate? So if this fluid is look like cloudy, like this picture number B, it indicate infection or peritonitis. If it is brown outflow, indicate bowel perforation. Urine color outflow indicate bladder perforation. Or if it is blood, mean blood coming out, right? So complication of peritonitis, insufficient outflow, sometimes causes the insufficient outflow. The main cause of insufficient outflow is a full of colon. And always make sure patients do not have any constipation. So educate or encouraging your patient to take the fiber containing diet. And insufficient outflow may also be caused by catheter dislodgement or migration, displacement, or always another cause of insufficient outflow can cause the bending or kinking. Suppose you gave 2-liter fluid, but outflow is not as 2-liter or very scanty. Maybe the full of colon, maybe the constipation, maybe dislodgement, maybe the bending or kinking the outflow, or any times of blockage of because of clot formation, right? So first of all, what you could do, tell your client to turning their positioning, client to change side lying position, right? Sometime another complication cause the protein loss, too much protein loss through the dialysis. In that case, we increase the protein in diet. Or if hyperglycemia, we give them insulin as needed. So if the poor outflow or inflow, we will check the kinks in the tubing. So addressing constipation or reposition your patient, right? In case of leakage around the catheter site, so clean the fluid that leaked and takes 1 or 2 weeks after insertion of the catheter before develop fibroblast, and small amount of dialysate must be used, and it may take up to 2 weeks, right? So here we go to talk about the continuous renal replacement therapy, shortly called CRRT. So continuous renal replacement therapy is a special type of dialysis that we do for unstable patient, especially unstable patient in intensive care unit or ICU. The patient whose or those bodies cannot tolerate regular dialysis. Instead of doing it over the 4 hour, the continuous renal replacement therapy is done 24 hours a day to slowly and continuously clean out, as I told, clear out the waste product and fluid from the patient. The continuous renal replacement therapy, what we need to know for board exam. Let me read it. This is the device we use for continuous replacement therapy. So continuous renal replacement therapy provide continuous ultrafiltration of extracellular fluid and cleaning of the urinary toxin over a period of 8 to 24 hours, and used primarily for the client in acute kidney injury or critically ill client with chronic kidney disease who cannot tolerate hemodialysis or regular dialysis, water, electrolyte, and other solute are removed as a client blood passing through the hemofilter. Because of rapid shunt in the fluid and electrolyte typically do not occur, and hemofiltration is usually well tolerated by critically ill client. There are 5 variants of continuous renal therapy. Some require hemodialysis machine, whereas the other is relay on the client blood pressure to power the system. So this is the machine we use for continuous renal replacement therapy. So instead of the doing it over the 4 hour, because the hemodialysis take 4 hours per session, 3 to 4 times per week. But in this continuous renal replacement therapy is done 24 hours a day to slowly and continuously clean out the waste product and fluid from the patient body. And now we are going to focus the last point today, kidney transplantation or kidney transplant, right? So the pre-procedure is important before to start transplant. We always keep in mind, provide immunosuppression therapy as ordered or as prescribed. So a human kidney from a compatible donor is implanted into the recipient. So the person who give the kidney we call donor. The person who received the kidney we call recipient. So after matching the donor and recipient tissue type, blood group, or histocompatibility complex, then we decide to transmit. In this picture, you can see original kidney, but that does not work at all. And we need, if they transplant kidney implanted inside the body, and the old one just left up there. So the kidney transplant is performed for irreversible kidney failure, like CKD, end-stage renal failure. And specific criteria are established for eligibilities for transplant. The recipient must take immunosuppressive medication for lifelong. And I said the pre-procedure provide immunosuppression therapy is prescribed. Same picture, we repeat, kidney transplant, diseased kidney and transplanted kidney are implanted and attached in the iliac arteries. And old one is left. Donor, first of all. And also it is important to educate your patient pre-procedure and after procedure. So what is important from here, the donor may be living donor or donor might be cadaveric donor. So living donor means related or unrelated to the client, maybe family or friends, or sometimes by it, or non-heart beating donor. Another number 2 type, non-heart beating. Just before to die, we collect the organ and we can collect the donor kidney from dead body is called cadaveric up to the certain time. The most desirable source of the kidney transplant is living related donor who closely match to the client. And non-heart beating donor are those who have been declared death by cardiopulmonary failure criteria and have the organ harvested immediately after death. And cadaver donor are those who have suffered irreversible vein injury, or this person are maintained with mechanical ventilation and must have adequate perfusion of the kidney. The physical criteria for donor, some of the criteria they have, and you have to exclude before donate the kidney. What is the criteria? You make sure the donor do not have any systemic disease or infection. Systemic disease like autoimmune disease or any infection like HIV, or no history of cancer, no kidney disease, no hypertension, or adequate kidney function. What else? Donors are scanned for ABO blood grouping, or tissue typing is called tissue specific antigen, human leukocyte antigen, and mixing the lymphocyte and culture index is called histocompatibility complex. And donors are also scanned for presence of any communicable disease, and they undergo a complete medical evaluation as well as the nephrologist consultant. So the kidney transplant group or team contained a surgeon, urologist, nephrologist, and registered RN who is very skilled in here. Donor must be excellent health, and their kidney must be properly, adequately functioning, emotionally well-being, and complete understanding of donation process, right? And next here, what are the pre-procedure and what are the post-procedure? Okay. So first of all, the pre-procedure, we check the histocompatibility test, and this test will be done by organ bank personnel. We start immunosuppression medication or suppression therapy before start. Will be admin to the recipient and maintain the strict aseptic procedure, assist to verify the hemodialysis of the recipient may complete 24 hours before transplant, and ensure that the recipient is free for any infection like STI or STD or HIV. Monitor the renal function study, encouraging the discussion of feelings of the live donor and recipient. Also, we could provide psychological support to the live donor or even the heart-beating donor or cadaveric donor. Post-operative intervention, what it is. So, transplant kidney is placed in the anterior iliac fossa. So, in here, this is the anterior iliac fossa, what we implanted the transplant kidney. And also, urine output usually begin immediately. Hemodialysis may be performed until adequate kidney function is established. Monitor the vital sign and monitor urine output hourly. Immediately report if urine output less than 100 ml per hour. We monitor the IV fluid closely, monitor daily weight to evaluate the fluid status, monitor daily laboratory result like creatinine, blood urea nitrogen, also specific gravity. Position the client in semi-polar posture, right? So it promotes gas exchange, turning from back to non-operative side, and monitor indwelling urinary catheter patency. So the indwelling urinary catheter remain in the bladder for 3 to 5 days to allow for anastomosis healing. So in a short, if I say the post procedure, we could monitor the urine output and report the urine output if it is less than 30 ml per hour and perform the bladder irrigation as ordered. Monitored for any kind of infection. So we could check the fever, erythema, incisional drainage, and also monitor for organ rejection. In this picture, we are seeing the implanted kidney in anterior iliac fossa, and incision is done in iliac crest to suprapubic area, inguinal canal, and here implanted kidney. So surgical incision for renal transplant, this one, and surgical placement of transplanted kidney. Here the post-operative intervention, and in this picture we can see the continuous irrigation. Okay, so post-operative. So note that the urine is pink or bloody initially, but gradually turns to the normal within several days to week. Right. So and notify the RN, who will notify healthcare provider if goes, hematuria, or clot are noted in urine. Hematuria means urine mixed with blood. Monitor the three-way bladder irrigation. So this is the catheter, Foley's catheter, and three-way, one for irrigation, one for urine drainage, and another for balloon inflect or deflect. So monitor the three-way bladder irrigation if present for clot. The RN may irrigate the catheter if healthcare provider prescribed is present. Assist to remove the indwelling urinary catheter as soon as possible and maintain aseptic technique and monitor for infection. So monitor for infection means symptom of fever, inflammation, redness, swelling, erythema, or any excess drainage. What next? Monitor for the bowel sound for passage the flatus. Monitor the oral hygiene and maintain the good oral hygiene. Monitor for stomatitis, encouraging coughing and deep breath in exercise. And also we assist to admin the medication as prescribed, or we have to observe to see the sign of organ rejection. So organ rejection means that transplanted kidney, the recipient body treat it is foreign body and reject, they do not accept the organ in their own body, and this is called rejection. So we monitor for organ rejection, like after transplant the kidney, we check for the fever, hypertension, pain at the site to implant. And there are three types of rejection. It is called hyperacute, acute, and chronic. Usually hyperacute rejection occurs within 48 hours of surgery. Acute rejection occurs within 1 week to 2 years, and chronic rejection occurs gradually, right? So in that times, we educate the patient to take low fat, high fiber, high protein, and low sodium diet, and also avoid the contact sports. Let me read it. So post-operative intervention for recipient. Monitor for the sign of organ rejection. Promote the live donor and recipient relationship. Monitor both the donor and recipient for depression. Assist to provide recipient with instruction following kidney transplant. Assist the recipient to cope with body image and assist to provide the recipient to available support group. So here talking about the monitor for organ rejection, like graft rejection. So except for identical twin donor and recipient, the major post-operative complications are organ rejection or graft rejection. As I told you, we could check for the fever, hypertension, and pain at the site. It indicates organ rejection. Organ rejection categorized in three: hyperacute, acute, or chronic. Hyperacute rejection occur within 48 hours of surgery or after transplant. Intervention, remove the injected kidney. Unlucky patient. Acute rejection occur within 1 week to 2 years. So in that case, we potentially reverse with increase the immunosuppressant. So if we increase the dose of immunosuppressant therapy, sometime it will be okay, right? And here showing the clinical sign of renal transplant rejection, like temperature, means fever higher than 100 degrees Fahrenheit or 37.8 degrees Celsius. Pain or tenderness over the grafted area. Weight gain in 24 hours. Edema develop. Hypertension develop. Patient feel malaise. Elevated the blood urea nitrogen, serum creatinine, or decrease the creatinine clearance, elevated white blood cell count, and rejection indicated by ultrasound or biopsy. The chronic rejection occur gradually, right? So occur slowly month to year. What are the intervention? Immunosuppressive medication and retransplant if necessary, right? So that is the most information about the kidney transplant. I want to recap something, finish to this PowerPoint. During this stage, we educate our patient for low fat, high fiber, high protein, and low sodium diet, and avoid contact sports. And Clex board frequently asking this question.